All right, we are now recording. Last week we covered the first half of inner ear disorders, and we mostly focused on some of the anatomy, physiology of the ear, because that's always worthwhile to review. And then we launched into presbycusis, which is the big one. That's the main pathology that you, as HISs, will be dealing with on a regular basis. And now what we're going to be doing today, because the inner ear pathologies require at least 2 weeks of coverage in an 8-week course. I mean, that's the lion's share. So that's why we're spending week 2 on this one here as well. So now today we're going to start out with noise-induced hearing loss, which is the second most common cause of inner ear pathology. And the saddest thing about noise-induced loss is that it's preventable. I mean, we don't stare into the sun because you know you're going to go blind. And yet, for some reason, people think that the ear is impervious to the ravages of noise. And it's a real truism to say that elderly people in Africa have better hearing than elderly people do in the US and Canada. And the reason they do is because they have less noise pollution. There's less industrial noise pollution. And to be perfectly honest, our ears were meant to hear soft voices over the crackling of a fire. Our ears were never meant to hear the clanging of steel on steel. That's the Industrial Revolution. That's what machinery did to us. Okay? So while machinery has been great in helping our quality of life, it certainly has not been great for the health of our ears. Hair cells are destroyed very easily by excessive noise. So I will share screen here, and we'll go over to where I have this one weird little PowerPoint. Oh yeah, here we go. Pull up this puppy, noise-induced loss. So you're looking at the second most common cause of hearing loss, NIHL. Noise-induced loss has an interesting shape, and it's this shape that I think everybody in this field gets to know very well. There is a telltale shape to noise-induced loss, like a visual giveaway that just kind of, oh yeah, you've been exposed to noise. You know, one time in Arizona, I used to live in Tucson, and I studied at University of Arizona. And there was these 2 teenagers who were brought in by their mother. And I did hearing tests on both of them. One was 16 and one was 17. One had noise-induced hearing loss in his right ear. The other one had the same kind of noise-induced loss, mostly in his left ear. And I thought, well, that's weird. And then I caught a notion. I said, is one of you right-handed and one of you left-handed? And the guy with the hearing loss in the right ear said, yep, I'm left-handed. The one with the hearing loss in the left ear said, yep, I'm right-handed. I said, do you do target practice, rifle, trap shooting? You know, do you, yep. Oh, yeah, one guy holds the rifle like this, so his left ear gets most of the sound. The other guy holds the rifle like this, so his right ear gets most of the sound. Noise-induced hearing loss. I said, better wear earplugs. It's permanent. It's not going to get any better. It'll only get worse. But you can stop it from getting worse by wearing earplugs. So it's really the interesting thing about noise-induced hearing loss. When you look at this picture here, the shape, it's going to be excellent hearing in the lows and middle frequencies. Even 2,000 hertz is going to be fine. So this person is probably going to be the hardest person in the world to fit with hearing aids. This person here can hear quite well without hearing aids. In fact, talking on a one-to-one basis, you'd never even know the person had hearing loss at all. Because the hearing, look at speech. What's the pure tone average on here? It's about 10 or 15. Here it's at 20. He's got excellent hearing. Perfectly normal hearing. His pure tone average is normal. His SRT, normal. It's going to be the same as his pure tone average. His speech discrimination under headphones, probably 100%, 95, excellent, because he's hearing in quiet. His problems are going to be hearing in noise. You're going to hear better than he will. In a noisy bar or in a noisy restaurant, leaning over the table to better hear the person across the table, this person's going to be quite lost, okay? Because a chain is as strong as its weakest link. So one-on-one, in quiet, no problemo. In noise, yep, he's going to have more difficulty than normal, okay? He's also the hardest person in the world to fit with hearing aids because he can hear without his hearing aids. The best, I think we said last week, the easiest person to fit with hearing aids is someone who's got a severe hearing loss. Like, follow my cursor, 70, 80 across the board. This person here, easy peasy Japanesey, because he simply cannot hear without his hearing aids. And so to him, the glass is half full. Hey, you know, I love my hearing aids. They connect me with life. Without them, I'm screwed. But this person here, he can hear quite well without his hearing aids. And so he's more of a difficult cookie to please. And you're going to find that in clinic. The better the hearing is, usually the harder they are to fit. They want the hearing aids to make their hearing perfect, and they can't understand why they aren't doing that. They're going to be the glass will be half empty for mild to moderate loss. Of course, you should try and fit them, of course, but this person here, I would probably, you know, it'd be a toss-up whether I'd fit this person or not. He may really want to try hearing aids. Go for it. Yep, I'll program the hearing aids to fit just the high frequencies. Yep. Okay, definitely I'll encourage him to try hearing aids, but I will not be surprised if he returns them for credit. I really won't be surprised. So I guess that's my take here. Now, if you follow my cursor, if the hearing goes more like presbycusis on a slope, well, yeah, definitely hearing aid territory. Okay, but I'm just cautioning you about this particular loss. Look at what it says on the left here. Noise tends to damage hair cells a half an octave higher than the frequency of the noise. That's because the traveling wave in the cochlea, the peak of the traveling wave, is a little bit higher just beyond the frequency. Let me see if I can describe that. Here we go. Here's the outer ear canal resonance. Now look at when you look at the shape of noise-induced loss, ask yourselves, why does it go up again at 8,000 hertz? Why does it look like someone took a bite out of 4,000 hertz, and yet 8,000 gets better? That's a real good question to ask anybody, because many audiologists don't come up with a satisfactory explanation of that. Here's why. It's because of your outer ear resonance. Look at the shape of your outer ear canal resonance. The reason why our ears have this particular shape, with a helix, antihelix, concha, tragus, and then your ear canal being 2.5 centimeters long or 1 inch long, an inch long. Why? What does that do? Remember what you learned in acoustics? It's a quarter wave resonator, and it resonates with frequencies 4 times the length of the ear canal. It's like a cup. It's open at one end, closed at the other. Okay? So it's going to resonate with frequencies that are 4 inches long. And if you do the math from acoustics, that's going to be around 3,400 hertz. Okay? But your ear canal isn't made out of glass like this cup is. Your ear canal is made out of flesh and bone. So that resonance is going to be spread. And that's what I'm showing you here. Generally spread out. Okay? It's going to start at about 1,500 hertz. It's going to die out at about 4,000 hertz. The point is, it really hurts. No, this is the reason why noise-induced loss has its shape. Now, if you take that resonance that I showed you and you shift it a half an octave higher, you slide it a little bit to the right and turn it upside down, you've got the noise-induced loss. There you go. So that shape is from this being slid over a half an octave. Your outer ear, the gift of the outer ear, helping you hear high frequency consonants. As we've always said, the ear is made for speech, and the high frequency consonants are softest. So the ear is naturally an aiding device, and how much does it aid? By about 20 decibels. That gift is turned into a curse when it comes to noise. Okay? That's kind of how to look at it. Noise-induced hearing loss and the half-octave shift. Excuse me. Most industrial noises are broadband in frequency. They're like a pink noise or white noise. They include all different frequencies, lows, mids, and highs. Blah, 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 blah. You know, the noises of industry. The external auditory meatus, or ear canal resonance, creates a band pass centered around 3,000 hertz. There you go. So it takes that broadband noise and it filters just this section of it, just that where it resonates. It takes that and favors it and amplifies that section of the noise by about 20 dB. And then in physiology, we study that the basilar membrane, the floor upon which the hair cells stand, all the hair cells are standing on that floor in the scala media. Well, the displacement, the peak of the traveling wave is actually about a half an octave higher than the frequency of the stimulus. No need to really worry about memorizing that, but just basically know this, that the half octave shift means basically this resonance in the cochlea is shifted about a half an octave higher. You flip it upside down, and what do you got? Noise-induced loss. So the reason this gets better in the high frequencies is because this gets worse in the high frequencies. You're just flipping it upside down. So noise-induced loss is kind of like a result of this outer ear canal resonance. It's meant to be a favor for hearing high frequency consonants, but it's a bit of a curse when it comes to noise. So you're looking at postmicrographs of the 4,000 hertz region in the organ of Corti in a non-noise exposed control and a noise exposed animal. Normal noise, and there's the loss at around 4,000 hertz. Weird. Okay, I think this is outer cells, basilar membrane, no matter, but it's just, so when you think about noise-induced hearing loss, the summary of 5 studies on predicted permanent threshold shift for 3 exposure levels, and you've got 85, 90, 95, whenever you see the A, dBA, all that means, that always deals with noise exposure. It's dBSPL, okay? But remember how your hearing across the frequencies in dBSPL is uneven? Remember how because of the resonance of your outer ear and because of the resonance of your middle ear bones, your hearing, there's like a smile. Your hearing is better between 5, 1, 2, and 3, and 4,000 hertz. Okay, that's where the sweet spot of hearing is. We don't hear 125 hertz very well, nor do we hear 8,000 as well. And then we said that we call that minimal audible field. Remember, what's the softest it takes to hear all the different frequencies at 1 meter distance from a speaker with 2 ears. And then we studied minimal audible pressure. What's the softest it takes to hear all the different frequencies with 1 ear under a headphone? And we called that minimal audible pressure, MAP. And then we said that 0 dBHL is minimal audible pressure, right? Well, there's that uneven hearing sensitivity is built into noise exposure studies. So when people are using a sound level meter, they are making it read in dBA, which takes into account our uneven hearing sensitivity across the frequencies. In other words, if 125 hertz is really loud, dBA says, that's okay because we can't hear 125 hertz all that well either. Okay, it takes us about 40 or 50 decibels to hear dBSPL, to hear 125 hertz. So let's be fair. If 125 hertz is 85 dBSPL, that doesn't really matter. Okay, so that's what dBA just means. As soon as you see dBA, think, that's a noise. That's noise. They're studying noise. Okay, so anyway, you got all these different investigators that investigated how many hours could you tolerate 85 before getting noise-induced hearing loss. And then some people, how many hours would it take? 5 studies on you're going to get, if you're listening to 85 dBSPL, you're going to get various degrees of hearing loss. 90 dB, you're going to get greater hearing loss. 95, you're going to get greater hearing loss. So basically, the rule of thumb is around 85 decibels for 8 hours will cause permanent noise-induced hearing loss. 85 and 8, that's the way I remember it. And then if you get exposed to 90 dB, okay, generally, and here's a table. I think this is out of Yoast. This is a table out of a textbook here. Some people, in some states, the rule is 8 hours at 90 dBA. And then if you cut the hours of exposure in half, 95, you're only exposed for half the time. And if you go up by another 5 dB to 100, it's only 2 hours. And if you go to 105, you only got 1 hour. Okay? And so basically, as you go up by 5 dB, your time of exposure gets cut in half. Some states, it starts at 85 dBA for 8 hours. Some states, it's 90 dBA for 8 hours. Either way, 85 or 90. And as you increase the decibels by 5, the time of exposure from 8 gets cut in half. And go up by another 5, now you're down to 2. And another 5, now you're down to 1 hour. Down another 5, you're down to a half an hour. Noise is the second most common cause of sensory neural loss. Sensory neural loss is 95% of hearing loss. And 95%, I'd say about 60% of sensory neural loss is presbycusis. The remaining 40 is noise-induced hearing loss. It's a real big one. And I shouldn't say the remaining 40 because there's a few other little causes of sensory neural loss that we will cover after. Okay? If I look at let me grab my notes over here and make sure that we've covered everything that we need to cover. All right, here we go. Ototoxicity, presbycusis, noise-induced loss. Okay, let's just make sure we've got this puppy covered. Okay, stop sharing. So now you got to look at my ugly mug again. Okay, noise-induced loss is about a whole section of a page on that. Much worse in our loud society than in places like Africa. It can be temporary threshold shift or permanent, TTS or PTS. TTS is what you and I have experienced from listening to a loud concert. And your ears are ringing afterwards. Next morning you wake up, the ringing is gone. When they do noise-induced hearing loss testing at factories, they never test at the end of the day. They always test first thing in the morning because you've just had a night's sleep and all your hair cells can stand back up again. Everything is kind of like you've had quiet. If you've been exposed to the noise for a while, your hearing is going to be a little bit worse and you'll have some ringing in the ear. I always look at this analogy, kind of like if you walk over blades of grass, if you walk by your living room window, the blades of grass will get crunched down, but then later on they'll stand back up again. But if you keep walking over the blades of grass, now you killed it. Now you wore a pathway. I guess that's the analogy. That's how I would be explaining it. to a soldier or someone who's exposed to noise on a regular basis, trying to warn that person to wear ear protection if he possibly can. You know, just that's the kind of the analogy I would share with it. Sensory neural loss. Oh yeah, tinnitus is a common complaint. Tinnitus. Noise, presbycusis does not always cause tinnitus, okay? But here's what you could say, and you might want to jot this down as a word of advice to an elderly person who's experiencing tinnitus. We did say last week that aspirin aggravates tinnitus. Aspirin taken for blood thinner and arthritis is good for you, but I mean, it tends to aggravate tinnitus. But at least then the person knows why and what it is. Now, tinnitus, if you're talking to an elderly person, you might say, tinnitus is actually not all that loud. It's just that in dead quiet, you hear it. And when you had normal hearing, you could hear ambient room noise. And that masked the tinnitus. You couldn't hear it. But now you've got some hearing loss, so you can't hear the ambient background noise. So now you hear your tinnitus. And the silver lining to the cloud of tinnitus is hearing aids, because hearing aids are known to pick up background noise. So that curse is turned into a blessing when it comes to tinnitus. You see how I'm trying to always throw in clinical things that you may want to remember. Now, noise-induced hearing loss is often accompanied with tinnitus, because when you and I have listened to a loud concert, we come back and we hear ringing in the ears. Okay? Same with the person with noise-induced hearing loss. And that person's tinnitus will likely be, and I'll start sharing the screen again, will likely be at, I'll show you on the audiogram. Come on, stupid thing. Will likely be right here, around 3,000 hertz, right where the loss is dropping. That will be generally the pitch of the person's tinnitus. He or she's going to hear a high-pitched ringing in the ear, usually where the hair cells began to be damaged, right past 2,000 hertz, around 3. And when in hearing testing for noise-induced hearing loss, always test at 3,000 and 6,000 as well. Test those mid-frequencies. Always, that's where the hearing loss needs to be examined for sure. That's really what you need. Yes, Megan.
So my dad has hearing loss, pretty severe. And with his first set of hearing aids, his tinnitus got better, but now he's saying that the tinnitus is back. So does that mean, I mean, I know his hearing loss is degenerative, so is it at the point where his hearing loss has now gotten worse? And his hearing aids need to be bumped up in order to continue covering that tinnitus?
Hearing aids often have a tinnitus program.
Oh, okay.
That actually makes noise to cover the tinnitus.
Okay.
So you may want to have your dad see the clinician, because I'll bet you his hearing aids, how old are they? Are they less than 5 years old?
Oh, no. They're like 5 or 6 years old. He keeps repairing them just to...
Then they probably don't have a hearing aid program, a tinnitus program.
Okay.
Hearing aids that are 5 years old or younger, okay, the newer hearing aids today almost all have a tinnitus program on them. They actually produce noise. You can choose it too. Do you want a waterfall? Do you want a rainforest? What kind of noise would you like? It's really weird.
Right.
But yeah, it's time for your dad to get reassessed.
Oh, yeah.
Yep.
Oh, we know that.
Yeah. Oh, we know that. We hold these truths to be self-evident.
Yeah.
All right, I'll make sure that we're covering some of this stuff. Noise-induced, yep, we covered about 85 dB for 8 hours, blah, blah. Why does it result mostly at 4,000 and with some recovery in the high frequencies? We covered that. Many people have said, oh, stick with that 1 second here, middle of that noise-induced hearing loss. Some people say that the noise-induced loss, I'm going to share a screen again. Some people say that the noise-induced loss is normal in the lows because of acoustic reflexes. Because acoustic reflexes are strongest for the low frequencies, and they help protect the ear against noise-induced loss. BS. Acoustic reflexes
take your voice, right?
Yeah, and acoustic reflexes are mainly meant for your voice. That's correct. Because if someone's shooting target practice, the bang of the rifle is going to hit the ear way before the acoustic reflex can react. Okay? So this loss is going to happen regardless of acoustic reflexes. It beats the acoustic reflex in time, in other words, the noise does. I've heard other lies about, oh, the 4,000 hertz hair cells have a poorer blood supply. And some people say, oh, the foot plate of the stapes, as it pushes in and out of the oval window, tends to hit the 4,000 hertz region more, or whatever. There's all these weird, no, the real reason is because of the shape of the outer ear canal resonance. That's really the reason. Always do a case history to find out about the noise exposure. Make sure you test at frequencies 3,000 and 6,000 hertz. And here I'm going to just bring your attention here again. What will this person's most comfortable loudness levels be? What do you think he'll find as a comfortable loudness for speech? Remember you studied MCL in audiometry? What would this person's MCL be? What do you think?
Normal, wouldn't it?
Correct. Exactly. Dead on. Yep. Normal. This person's going to have a completely, his UCLs, normal. His SRTs, normal. Speech to scrim, normal. It's all like, oh, man. Yeah. Speech discrimination is excellent in quiet, and that's mostly how we test speech to scrim. Now, if you did speech and noise testing, you could find interesting stuff. And there's a lot of CDs that do this. The SIN test, as not in committing sins, but the speech in noise test is a CD that's commonly used, and it adds background noise, and you can tell how your client is doing in noise. It's something you may want to look up. Tympanometry. Person's going to have normal type A tympanograms because he's got nothing wrong with his middle ears. Hunters typically show noise-induced loss. Okay, here's showing progressive noise-induced loss, okay, as it gets worse and worse over time. All right, from 1 to 9 years, and then from 5 to 39 years. I mean, just look at how the noise-induced loss starts to spread. This is talking about noise-induced loss again, the shape of it, kind of some weird esoteric studies showing normal hearing loss due to age and then noise-induced hearing loss added to it. This is the slide I wanted to show you, though. Here's a person with the noise-induced loss who passed away, and they were able to look inside his cochleas. Inner hair cells are all fine, and then they got damaged. Outer hair cells, 3 rows of them, they were all fine, and then they got damaged. But this person was exposed to a lot of noise. Look at that, 80 dB. So remember sensory versus neural. Remember moderate sensory neural loss. Sensory loss is due to outer hair cell pathology. Outer hair cells die before inner hair cells. So when you've got a severe hearing loss like 80 dB, you can rest assured you've got outer and inner hair cell pathology, and that's precisely what this person's got. Okay? Associate outers with sensory loss, associate inner hair cell with neural loss, hence the term sensory neural. This is the picture I wanted to show you, though, of the hunter. Okay? Cytocochleograms of 2 ears of a patient who was a hunter. And you can see how the inner hair cells, the solid line, 3 rows of outer hair cells in his right ear, inner hair cells in his left ear, and 3 rows of outer hair cells in his left ear. Look at how the damage is worse in his left ear. And again, that's because the person was a right-handed hunter. And a right-handed hunter the rifle is going to be loudest to the left ear. A right-handed hunter has 10 pounds of ugly fat protecting his right ear. Okay? Anyway, just the story of some noise-induced hearing loss. We can now move on to a less common cause of sensory neural loss, and that's Menieres disease. Now, Menieres disease, named after a physician called Prosper Menieres in France. Look at the loss. Okay? Oh, by the way, before we leave noise-induced hearing loss, I mean to show you this picture because noise-induced hearing loss is not always symmetrical. Okay? This guy's is. Okay? Happens to be. But remember, the hunter, right-handed or left, or the truck driver, has got a window, left windows down. It's going to have more hearing loss in his left ear. Okay, so noise-induced hearing loss can be quite asymmetrical. That's where a case history is important to study. Menieres is also unilateral, or Menieres is almost always unilateral. It's one ear. Rarely, sometimes it'll get the other ear as well, but usually later in time. Hope to God it doesn't. Menieres disease is awful. Menieres disease is caused by too much endolymph fluid in the scala media. Not the scala tympani, not the scala vestibuli. They call it endolymphatic hydrops. Way too much endolymph fluid in the scala media, which is where the hair cells are. In that triangle, the inner triangle of the cochlea. So you got your scala media at the apex, scala media at the base. What we did here in orange is I've simply unrolled it, laid it across the top of the audiogram. So all we did was, in theory, we took out the scala media and just unrolled it. Okay? So you would have, if you follow my cursor, one row of outer hair cells here, of inner hair cells here, all the way from apex to base, and then you would have 5 rows of outer hair cells here, 4 rows of outer hair cells here, 3 rows of outer hair cells here, right? So always remember the apex of the cochlea, apex, like I'm doing with my fingers here, that's the tippy end of the cochlea. The small end of the cochlea has the widest scala media. The scala media gets narrower and narrower toward the wide base of the cochlea. Always remember, it's back-asswards to the way you'd think, okay? So you have more rows of outer hair cells. You have a bigger scala media at the apex of the cochlea, which you would think would house the smallest end. And you have the narrowest scala media at the wide end of the cochlea. Okay, now hold that in your heads. It's very important to understanding why Menieres rises. Look at the X's. Look at this guy's left ear. His hearing loss is worse in the lows and gets better in the highs. And you think to yourself, why is that? Why would Menieres disease cause a reverse rising hearing loss, which is opposite to any other sensory neural loss? And the reason why is because when you look at this apical area here, why do these hair cells get stimulated with low frequencies? Because there's more mass and less stiffness. That is why, W-H-Y, that is how come low frequencies make a traveling wave at the apex of the cochlea. 125 hertz will make a traveling wave peak here. 8,000 hertz will make a traveling wave peak here at the base. But you have to ask yourselves, why? Always. Because Remember, sounds don't enter a cochlea. I'm going to stop sharing here and emphasize the point. Sounds don't enter the cochlea. And I would repeat that as sounds don't enter the cochlea. They can't. Sound. Do you know how long a 250 hertz tone is 4.5 feet long? Okay, that's the wavelength. It's 4.5 feet. You studied acoustics. You could figure it out. Wavelength equals speed of sound over the frequency. 340 divided by 250, 340 meters per second divided by 250. You're going to end up with about 1.5 meters. So if you do that in inches, okay, and miles an hour, or, it's 1,130 feet per second divided by 250 hertz, you're going to end up with 4.5 feet. It's just, that's the length of the sound wave. How long is the cochlea when you unroll it? 1 inch. So a 4.5 foot sound wave can't enter a cochlea. They don't. Frequencies, airborne frequencies create traveling waves in the cochlea. But traveling waves are not sound waves. Traveling waves are ripples of the basilar membrane. So, sound waves are one animal, traveling waves are another animal. These are lions, these are tigers. They can't mate, they can't produce babies. Okay, they're different animals. So, knowing that to be the case, now we'll stop sharing. Go back or start sharing again, and you're looking at the traveling waves from a low frequency sound will make a ripple near the apex of the cochlea. And why? Because the basilar membrane, the floor upon which the hair cells stand, has more mass, and lows resonate with mass. It's also less stiff. Lows like that, okay? If you look at the basilar membrane, the scala media floor upon which the hair cells stand, if you look at that at the base of the cochlea, well, it has way less mass, plus it's way thicker, it's stiffer. And that is why high frequencies make a traveling wave here, okay? So now take the pathology of Menieres disease, which is excess endolymph fluid. Take excess fluid, blow air into the balloon, and where is it going to give? Where it's least stiff. So the scala media will bulge with excessive fluid at the apex of the cochlea. Why? Because the walls are less stiff. There's more mass, but it's less stiff. And excess pressure fluid will affect and bulge the whole scala media where its walls are less stiff. And that is the reason why Menieres rises.
I have a question on Menieres.
Pardon me?
I have a question on Menieres. Is it something that you can get when you're like 70-something years old?
It mostly hits you when you're younger than that. It can hit you at 70, it can, but it usually hits people at a younger age than that. I've seen it hit people at 30 years of age.
Because my stepdad is having a bunch of symptoms. He's going to the ENT tomorrow. He already had severe hearing loss from being in the service. He already had tinnitus from being in the service.
Yeah.
And now he's got these horrible episodes of vertigo and feeling disconnected. And my mom says, like, he has to move his chair right in front of the TV because he just can't comprehend. Mm-hmm. And to me, that sounds a lot of the symptoms of Menieres.
Well, I'll tell you, Menieres is a funny one because there's lots of pathologies that can be caused by excess endolymph, but it isn't always true Menieres. True Menieres is this. It's episodic, just like a seizure. When the person gets an aura and knows that he or she's going to have a seizure, and make sure to get into a good situation for that. Same with Menieres. It's like, oh shit, I'm going to have another attack. Uh-oh.
Yeah, he kind of knows, and and sits down and he says he said it's absolutely horrible. And
I'm not.
the thing is, they took him off of antihistamines but he also had a head injury before all this happened, but they did all the scans.
I'm not sure whether his would be characterized as true Menieres or not. I'm not sure. What happens is you get an episode coming on and you get three things happening at once. Rotary vertigo, not like dizziness. You're going around and around and you're puking your guts out. Okay. The second symptom is
nauseous thing.
Roaring tinnitus, not high-pitched ringing like noise-induced. It's roaring tinnitus, rotary vertigo, and sensory neural loss. Those three things. And then, after a couple hours, it goes away. And the sensory neural loss is almost normal again. But then, 2 weeks later, you get it again. And this time, it hits again. You're puking your guts out. You've got that roaring tinnitus, but your hearing loss doesn't improve all the way. Now you've got a bit of permanent low-frequency loss. In a month's time, it happens again. And now you get the same horrible symptoms. After a couple hours, they fade away, but now you're left with still more low-frequency loss. And what doctors do is they often just recommend that let the disease run its course until it's done. And usually it lasts about several years. You wouldn't want to wish this on your worst enemy. It's a horrible disease. They do not know the cause. They don't know the cause. Some say it's like autoimmune deficiency in the ear, like the ear fighting itself, like cancer is like that, or allergies, like the body just doing something stupid. We don't know the cause of Menieres, but read with me in the notes here. I'll read with it. It's awful. Suddenly, it would be on the next page. Sudden paroxysmal episodic symptoms of vertigo, sensory neural loss, tinnitus. Usually unilateral. Bilateral cases, maybe 5 to 10%. Client reports a full feeling in one ear, and then low-frequency roaring tinnitus and hearing loss. Rotary vertigo, extremely handicapped, and it has remissions caused by endolymphatic hydrops, over-secretion or under-absorption of endolymph, causes excessive pressure causes hearing loss and tinnitus. More pressure causes vestibular system to become overstimulated with resultant vertigo. Some argue that excessive fluid buildup alone cannot be the only cause. It must be blah, 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 blah. Glycerol tests. Glycerol, used to diagnose Menieres. Person drinks about 6 ounces of a 50-50 mixture of glycerol water to make you pee. Okay, it's a diuretic. And they want to show, hey, did that show a little bit of improvement? Then you probably have Menieres. Because when we decreased fluid pressure in your body, your Menieres got a little, that got a little better. So, but treatment, diuretics, reduced salt intake, tranquilizers, vestibular suppressants. Sometimes, read the bottom line, sometimes people opt for a labyrinthectomy. In other words, kill the ear. Please kill the ear. I can't stand it. I'd rather be deaf in one ear than go through this hell. So that's the kind of pathology. It's not nice. That's why when you're talking, Kelly, about your father-in-law, I'm not sure, because Menieres has a lot of different cousins, okay? But true classic Menieres is those 3 symptoms: rotary vertigo, okay, roaring tinnitus, and sensory neural loss. You have to have all 3 together to call it true Menieres. The other cousins or variations of it are often known as endolymphatic hydrops. Okay, but classic Menieres is an endolymphatic hydrops of those 3 classic symptoms. If you look over on the prior page, sudden idiopathic deafness, we can only just talk about that one. Sudden idiopathic deafness. I don't think I have a slide of that. I'm not sure, but I'll check it out. Here we go. Oh yeah, this is picture showing you about Menieres. Here's a look at the scale of media, getting wider toward the apex of the cochlea. This is another picture showing you the very same thing. Look at how the scale, look at how the basilar membrane here. As you go higher up in the cochlea, it gets longer. Higher up in the cochlea, see that? So your scale of media actually gets bigger, more mass, as you get toward the apex of the cochlea. It's smaller toward the wide base of the cochlea, as seen in this shot and in this shot. Okay, both of them. This is just the unrolled cochlea. Okay, now I'll just leave that picture there and stop sharing, and I'll just talk. We'll just look at sudden idiopathic deafness. Sudden idiopathic deafness. Read with me. Usually hits young people. Usually hits people around 20s, 30s, maybe in the 40s, but it's a strange, all of a sudden you wake up in the morning and you're deaf in one ear, or you got a real hearing loss in one ear. How come? Nobody knows. My daughter, who's handicapped, she had a caregiver, a nurse, young lady, young married lady, 25 years old. She had a child of her own as well. And yeah, this nurse woke up in the morning. This is a true story. And just deaf in one ear. Just gone. And she lived in Canada, of course. And in Canada, to see an ear, nose, and throat doctor, you have to get a referral from your family doctor. Well, by the time she got a referral from her family doctor, the damage was permanent. It's gone. Okay? If someone gets sudden idiopathic deafness and comes to your office, I would drive that person over to an ENT now. Just get in the car, we're going. Because the ENT will put the person on steroids. Corticosteroids are the only treatment, and it better be done within 48 hours of the symptoms. Otherwise, the ear is dead, and it ain't coming back. They call it sudden idiopathic. Idiot means you don't know anything. Well, they don't know the cause. Sudden idiopathic deafness. Gone. Accounts for only 1% of sensory neural loss. Very rare. Affects one ear with almost complete deafness. Onset of hearing loss occurs within 3 days or less. Steroids often prescribed, but not always successful. 15,000 cases annually reported around the world, about 5 to 20 cases in every 100,000 people. Only 10% of cases receive a formal diagnosis, and this is why it's called idiopathic. Here it says most commonly at 50 to 60 years of age, but I've seen it in much, much younger people. Often accompanied by vertigo and tinnitus. Vasospasm of the internal auditory artery could be a cause. Who knows? Whatever. I'll never ask this on a test. It's just, it might be attributed to an autoimmune system disorder of the inner ear. Anticochlear antibodies. Autoimmune system. Who knows? We don't know. There's another cause of sensory neural loss. So now you got 4 of them. Presbycusis, noise-induced loss, Menieres, sudden idiopathic. We also covered last week ototoxicity, right? So there's a 5th one. Oh, all these lovely things. You'll read in your notes something like head trauma. Yeah, you get a good whack on the side of the head, and if you get a longitudinal fissure of the temporal bone, crack, open goes the cochlea, the fluid leaks out, and you're dead. I mean, you're not dead. The ear's dead. Okay, that can cause it. Rare. I'm going to show you, and we're going to finish today with a weird thing called cochlear dead regions. Cochlear dead regions. This is trippy. Now remember what you studied in anatomy class. Here's a low frequency traveling wave. Here's a high frequency traveling wave. Okay, this white line is your basilar membrane. That's the floor of your scala media. This is where all your hair cells are standing up. All we did was we unrolled the cochlea. So this is 1 inch long, this whole thing. The rumbling of a truck, blah, 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 is creating low-frequency traveling waves that activate the apex of the cochlea. The peeping of a canary in your kitchen, beep, 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 is activating a high-frequency traveling wave that's confined toward the base, right? Right. Now, let's say Miss Canary is peeping away in your kitchen, beep, 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 and the truck across the street is rumbling, blah, 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 blah. The blah, 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 blah of the truck will mask Miss Canary, because look at her, she's peeping really soft, beep, 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 beep. Look at how the traveling wave is shaped like a kite. Look at how the red shape, just like one of these kites that you fly. The envelope, the shape of the traveling wave is asymmetrical. See that? How it has a steep front and a long tail. And because of that shape, a low-frequency rumbling truck can easily cover the soft peeping of a canary. This is why low frequencies mask high frequencies, but it doesn't go the other way around. It's called the upward spread of masking, and we learned about it in psychoacoustics. Now we're coming back to it in hearing disorders. All has to make sense, because look at this slide. Look at this next one. It doesn't work the other way around. You can have the soft rumbling of a truck across the street, and Miss Hairy Canary can beep, 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 beep all she wants, but this wave ain't going out here. You see that? So high frequencies don't mask lows very well. Lows mask highs much better than highs mask lows. Okay? So the soft peeping of a canary is easily masked by the loud rumbling of a truck. But the soft rumbling of a truck is not masked by a loud, hairy canary who's pissed off. It ain't going to happen. So, when you look at a reverse loss, here's a reverse rising loss. If you did a good case history, you will have ruled out Menieres. Okay, this is not Menieres. Let's say person's not complaining of any dizziness, has had this all his life. Okay, it could very well be that these low frequencies here are dead. It could very well be that actually these O's for the right ear should be at the bottom. Let me just make a case in point. I'll stop sharing for a second. Let's say I went to Megan Ellis's house at night and made her, gave her chloroform to put her out. And then I took out every hair cell below 1,000 hertz from her right ear. Every hair cell. Left the ones above 1,000 hertz intact, but killed off every hair cell above 1,000 hertz. Guess what? Tested her in the morning for hearing. Her hearing would look like this. These thresholds wouldn't be at the bottom. They would be here. How come? Because when I'm stimulating the low frequencies with a traveling wave peak, look at this. I've unrolled the basilar membrane. We're laying it across the audiogram. Look where the tail of the traveling wave is. It's stimulating mid-frequency hair cells. She's going to raise her hand. Isn't that weird? So she's hearing, in quotes, these low frequencies with these hair cells. So even if all the hair cells below 1,000 hertz are dead, if I make the sound over 50 to 60 dB, the traveling wave tail will be big enough to stimulate healthy hair cells. She's going to raise her hand. That's why you should be very suspicious of low frequency losses, because many times these what I would do is I would play a tone in the dead area. I would play a 250 hertz tone and ask her, what does it sound like? Does it sound good? And if she says, no, doesn't sound good at all, it's probably a cochlear dead region. The dead regions. You can't fit with a hearing aid because there's no hair cells there to aid. Okay? Let's look at high frequency dead regions. Here's a high frequency dead region. Now looky, this one's even weirder. Let's say I went into Kelly's place one time at night and I killed off every hair cell in her ear above 1,000 hertz. Just took them all out. Left the low frequency hair cells alone. Tested her in the morning, her hearing would look like this. Now, how come? Well, let's say I tested at 1,000 hertz. The front of that wave would stimulate these healthy hair cells. Let's say I tested her at 1,500 hertz. I'd have to make the wave way more intense so that its front would stimulate the healthy remaining hair cells. If I went further into the dead region, I'd have to really make that wave intense for the front to stimulate the remaining healthy hair cells. And that is why high frequency dead regions have to be associated with A, a severe loss, and B, a precipitous loss. It has to drop like a stone. If you are aiding this person, don't chase after these frequencies where my cursor is. Don't. Repeat, do not. Fit the transition where my cursor is. You can help the dying, but you can't help the dead. So don't chase after frequencies that aren't there. These hair cells may be totally gone in the high frequency region. The hearing loss will have a very steep shape. It'll be precipitous and pronounced. But contrast high frequency dead regions to low frequency dead regions. How come this loss doesn't have to be plummeting down? Well, it's the shape of the wave. It's the shape of the traveling wave. In a weird way, this is like an audiometric snapshot of the low frequency traveling wave. In a weird way, this is like an audiometric snapshot of high frequency traveling waves. You know, if you take these black things and you flip them upside down, you got this. Anyway, it gets rather cerebral. Don't worry about it. But cochlear dead regions exist in people. Always do a good case history when you've got a reverse loss. This could be genetics, like a cookie bite loss, but it isn't, okay? And speaking of cookie bite losses, don't always fit the worst areas in the middle. Fit the transitions where the loss is going down. Always remember, you can help the dying, you can't help the dead. So always focus on the transition. With this person here, I would probably focus on aiding this middle area right here. I wouldn't even worry about this here because it's going to sound crummy. He's going to pick up so much background noise, it's unbelievable, because background noise is mostly low frequency. So you don't want to amplify the crap out of low frequencies. This person, I would probably counsel against wearing hearing aids. I would probably be like, you know what? You can hear the high frequencies pretty good. You might like sounds a little bit louder, but your crisp clarity of hearing is going to be excellent. So hearing aids, well, you can try them. But again, like noise-induced loss, be thou not surprised if he or she returns them for credit. You can try it. But again, so a case history like this, you've got to rule out Menieres disease. If this is genetics, then it's genetic. Play a tone in the low frequency region and ask the person what it sounds like. The quality. If it sounds lousy, then it's not going to sound good amplified with a hearing aid either. Same with this person. Play a 4,000 hertz tone. Just put it in his ear and crank it up until the person hears it. And ask him, what does that sound like? I'll tell you a case and example and I'll stop, okay? In Bellingham, Washington, I was getting my master's degree in audiology. And one of the things I had to do was test city employees. So I went to the cafeteria where this guy worked, and I had a bell-tone audiometer, and I had headphones on his ears. And he had a loss like that steep loss I'm showing you. His is a noise-induced loss. And I'm playing 4,000 hertz. I could even hear the tone coming out of his headphones. Okay, and I'm saying, don't you hear that? He goes, no, but it tickles. I feel it. I feel sort of a, well, he's got a cochlear dead area. That area's gone. Don't fit with a hearing aid, for heaven's sakes, because he hasn't got any sound quality there. 4,000 hertz amplified doesn't sound like a high-pitched tone. It just sounds like a scratch or a tickle or whatever. So always play the tone in the worst area and ask the person what it sounds like. If it sounds good, then aid there. But usually the best thing to do for some people like this is to basically aid, whoa, I kind of jumped ahead of myself. Gonna go ahead here. Aid the transitions. Kind of out to about 2,000. Focus your amplification there. Don't chase after these frequencies here. You're gonna get excessive feedback. Then you've got this guy here, left corner audiograms. Obviously both inners and outer hair cell loss. This person's going to have that nasal, that weird speech. Person here's going to be talking but like this all the time. He has that deaf beat. He doesn't know how to say high frequency consonants because he's never heard them. He has a left corner audiogram. Probably genetics, probably inherited from mom or dad. Maybe mom had rubella. Maybe that's how he was born. This person comes from a separate camp all together. When you are fitting this person with hearing aids, you are going to witness something very strange. He's probably going to be doing this. And ticking his finger. You're going to be thinking, are you on drugs? No. He's checking the sound of the new hearing aids to make sure it sounds like the old hearing aids. He has an intimate love affair with his old hearing aids. They were his link to communication. And by gum, if he's getting new hearing aids, they'd better sound exactly like his old ones. Oh, because that's what he's accustomed to. That's what his link. He has a psychology that's very different from the noise-induced hearing loss or typical Mrs. McGillicuddy who's got typical rolling down presbycusis. Very different psychology. He's coming from a different place. He's orally deaf. He could be using sign language, but if he's not, he's using his hearing aids, and he's using his hearing aids like crazy. So if you did word recognition, word descrim testing on this guy, he would probably get 10%. He would get terrible word recognition. He probably wouldn't even be able to repeat spondees back to you with SRT testing, because his hearing is so bad that if he can't see you, he can't do it. You may have to do speech awareness testing on him. Just raise your hand when you hear me talking. Ba, 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 and then lower it down. Ba, 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 lower it down. Ba, 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 ba. SAT, because he can't say horseshoe, hardware, cowboy. He probably won't get the words. He's got such poor hearing, he hasn't got any high frequency consonants to recognize anything. Okay? Do word recognition, you'll probably do 10%. And then I would read him a second list, and this time, let him see your face. And you will just see you'll see his whole face change. Because now he's using his he's got headphones on, but he's using his hearing aids. And he's lip reading. And you'll get a nice quantification. Hey, guess what? Your speech discrimination was 10% when you couldn't use visual cues, and it rose to about 65% when you could see me. And it just dramatically indicates, wow, how much he uses his hearing aids. It's really, he just comes from a different place. Anyway, I've kept you long enough. All right, we've done our inner ear disorders talk. Next week, retrocochlear pathology. Any questions? How are we doing? Good stuff? In Portland and in Boise? All right, cool. All right, you're in the car there, eh, Kelly?
Yes, I always leave Tuesday open, and I had an appointment scheduled for today. So
Yeah.
I'm like, well, I'll take
Hey,
my
great.
iPad.
Hey, well, thanks for showing up anyway. Appreciate it. All right. We'll see you later. I'll stop recording here. Pause.